Hi, I'm Mark Wayne. I'll be the moderator for this session today, and this session is intensive 4A, Part 1 and Part 2, this is breakout room number 4. The session will end at 3:35 today, because we've got an hour, I am going to go through and do the introductions and the bios for all of our speakers today for both Part 1 and Part 2. With Part 1, the topic is North Dakota Community Collaborations and Integrated Care Models Addressing Oral Health. And the speakers for this topic are Cheri Kiefer and Shawnda Schroeder. Cheri Kiefer is the Oral Health Program Director for the North Dakota Department of Health, Division of Health Promotion, and works with partners across the state to address oral health priorities and chronic disease prevention. She received her Bachelor of Science in Dietetics from the University of North Dakota and Bachelor of Science in Nursing from MedCenter One's College of Nursing. She has been working with the Department of Health for 6 years. Shawnda Schroeder is a Research Associate Professor for the Center for Rural Health at the University of North Dakota. Dr. Schroeder participates in rural health research, takes lead on state program evaluation, and leads graduate student internship and practicum experiences at the CRH. She serves as the director of the Rural Health Research Gateway, a website that provides access to research publications and projects funded through the Federal Office of Rural Health Policy. Under the Mountain Plains Mental Health Technology Transfer Center, Dr. Schroeder provides training on rural mental health and conducts research on stigma as well as mental health training needs. She is the lead for several oral health studies, serving on statewide and national oral health coalitions and work groups. She is a member of the editorial board for the Journal of Rural Health and is an elected member of the UND School of Medicine and Health Sciences Research Committee. Both of those presenters have indicated that this presentation will not include discussion of any commercial products or services and will not include any discussion of off-label and/or investigational use of any product or services, and will not include trade names. For the intensive 4A Part 2, the topic is Hepatitis C treatment in the primary care setting, increasing access to curative therapies. The first speaker is Amber Slevin. Dr. Slevin is a clinical pharmacist at the Family Healthcare in Fargo, North Dakota. She also serves as an assistant professor of pharmacy practice at NDSU School of Pharmacy. Dr. Slevin earned her doctorate of pharmacy from NDSU School of Pharmacy, completed her clinical residency at the Hennepin County Medical Center in Minneapolis, and then practiced at the Schroeder Gastroenterology and Hepatology Specialty Clinic in Milwaukee, Wisconsin for 3 years before returning to Fargo. She is a board-certified ambulatory care pharmacist and a certified tobacco treatment specialist. Her research, teaching, and clinical practice focus areas are in hepatology, gastroenterology, and common disease states encountered in a primary care setting. Dr. Slevin is proud to be part of an interdisciplinary team working to optimize the primary care-based hepatitis C care cascade at the family, healthcare, and beyond. This presenter has indicated that this presentation will not include discussion of any commercial products or services and will not include any discussion of off-label and/or investigational uses of any product or services. It will include trade names due to the length of the generic HCV medication names and common practice to refer to as brand names. Both will be used. Shari Renton is the other presenter with this topic, and she is a HIV, STD, viral hepatitis surveillance coordinator for the North Dakota Department of Health and has served in this role for the past 3 years. Cheri received her bachelor's degree in biology in 2013 from the Minnesota State University Moorhead and her master's in public health degree in 2016 from the North Dakota State University, specializing in the management of infectious diseases. In her current role, Cheri oversees the epidemiology and analysis of HIV, STDs, and viral hepatitis throughout North Dakota. So we're going to start out with Cheri and Shawnda talking about the North Dakota community collaborations and integrated care models addressing oral health.
Well, I'm going to just kick us off then. I am Shawnda Schroeder. I am an Associate Director of Research and Evaluation, and we only have 30 minutes between both Shari and I do not want to run into the next session, which I know will be excellent. So today I'm going to kick us off by actually pointing out everything that is wrong in terms of oral health prevention and outreach in North Dakota, but then you all get the good fortune of hearing Shari speak about all of the great work that's being done in North Dakota to really address those inequities. So I do like to start with a land acknowledgement statement. I am at the Center for Rural Health, and that is located at the University of North Dakota, and I'm actually in my office today, so I can actually say that I am sitting at the university, and we rest on the ancestral lands of the Pembina and Red Lake bands of Ojibwe and the Dakota Oyate. Objectives for today. So we're going to talk to you about the unique oral health issues in North Dakota. We're going to identify rural models or community interventions that have worked in North Dakota. And then we're going to hope that you can recognize and describe the different roles that health providers and health centers can play in addressing some of the oral health inequities in North Dakota. So oral health concerns are not just the responsibility of dental care teams, and in fact, they are not able to meet all of the needs in our state. And so we really rely on individuals like you all in public health, in the emergency rooms, in school systems and coordinated care centers and social work. We really rely on these interdisciplinary teams to address oral health inequities in North Dakota. So oral health and overall health, I know sometimes we feel like we shouldn't be talking about dental care at this conference or at a lot of different health conferences, but I just want to be really clear that oral health is completely and entirely related to overall health. Your mouth is not separate from your body. Poor oral health can lead to stroke and dementia, mouth cancer, diabetes, heart disease, respiratory infections. And these are all correlation, not causation, for those of you who are interested in research. Not brushing your teeth will not indefinitely lead to diabetes, but there is a correlation with poor oral health and unmanaged diabetes. So kind of looking at North Dakota, how are we doing? Not all that great in some areas. In some places we are doing well, but my job today is to show areas for improvement. So this is the percentage of third grade students who've had a Cheri. A Cheri is just another way of saying a cavity. So for both treated and untreated decay, you can see North Dakota, we're that dark blue. What that dark blue indicates is that between 61 and 75% of our third grade students in North Dakota have treated or untreated decay. That's about 3 out of 4. So that's a significant area where we can be working for improvement. And I do want to recognize that even the states that are doing really well, so those light colored states, they still have upward of 35 to almost 50% of their third graders that have a decay or dental caries experience. But Head Start, how are we doing in Head Start? Head Start's a program that's been developed to try to help younger children at a very early age meet their developmental milestones, and this includes oral health. So the percentage of Head Start children in North Dakota that needed dental treatment in the past 12 months, and those that actually saw a dentist, was a lot better in North Dakota, and we were doing significantly well in terms of them seeing a dentist. However, the percentage of children needing dental treatment is relatively high. So that green bar is indicating the percentage of our kiddos who are in Head Start in North Dakota that needed some sort of dental treatment. Yes. But here we have our percentage of kindergartners with specific oral health concerns. So the reason Head Start can be an extremely great partner and really influential in improving oral health is because we know that in North Dakota, by the time these kids get to kindergarten, only about half of them had a preventative visit in the last 12 months, so 48%. And then there was decay experience for almost 70% of our kindergartners in North Dakota. And there's also the indicator of need for earlier urgent care. And again, almost half of our kindergarten students are coming into school with need for earlier urgent dental care. And having dental pain or poor oral health, especially in a school-based setting at such a young age with a relatively low pain threshold, which is expected in a kindergartner, there's discomfort, there's pain, there's an inability to learn, trouble focusing, poor nutrition because it hurts to eat. So poor oral health can even impact their learning and their ability to focus in the classroom. So where and when is it important to evaluate oral health? Sort of sharing that data anywhere and always, but especially it's important to really ensure that we're using unique models of care to reach patients who live in rural areas, to reach patients who are Indigenous, and to reach patients who are Medicaid eligible. And here's proof. So, I think it was one of our keynotes this morning that basically said, don't trust anything unless you've got numbers and data to back it up. So here we go. This is evidence that our students in rural North Dakota and our individuals in rural areas are struggling with oral health concerns more than urban and more than the state overall. The bar chart you're looking at right now, this is North Dakota kindergartners, and you don't have to love data to recognize the trend here. That dark green bar, that teal bar, is bigger than all of the other bars, which means that, almost 1 in 2, a little bit more than 1 in 2 of our rural kindergartners needed earlier urgent care, 54% compared to 47% of all of our state. If we move over to decay experience, you can see that our kindergartners in rural communities had a greater percentage of them had decay experience, upward of 81%. They had greater untreated decay, rampant decay, and need for urgent dental care. So now this is our Medicaid enrolled children. This is the percentage of our Medicaid enrolled children, that's ages 0 to 21. This is the percentage of those who had a preventive visit and a percentage of those who had a dental treatment visit. If we even just look at the best we've ever done, which is in 2019, which means we're improving, but if we look at the best we've ever done, it's still only 30% of our Medicaid enrolled children even saw a dentist for a preventive visit in 2019. And these are kiddos that actually have, Medicaid covered insurance, and they're not seeing the dentist for preventive visits, and even fewer are having dental treatment. And this is the percentage of Medicaid enrolled children who received a dental sealant. I don't expect you all to know what a dental sealant is. I didn't either before I really dove into the world of oral health with Sheri, Kiefer, and her team. But basically, it's that clear coating that can be put on molars and can really protect a child from having any dental caries or cavities. So in a population that isn't seeing the dentist regularly, like we just saw among our Medicaid patients, you would really hope that when they do see a dentist, they're getting their teeth sealed so that will prevent future decay. And our percentage of Medicaid enrolled children that received a dental sealant is also low. Now here we're looking at concerns related to race. If you look over at the yellow bar, this is our American Indian and Alaska Native kindergartners. So kindergartners who are Indigenous in North Dakota have much worse, a greater percentage of them have worse oral health. So for an example, 93% of kindergartners in North Dakota who are American Indian or Alaska Native have had decay experience. I'm going to say that again because I think numbers are probably blurring in your head at this point, but 93% of those kiddos likely around age 5 in North Dakota in kindergarten who are American Indian and Alaska Native have decay experience. And almost half, or more than half, 54.3%, have rampant decay. That means decay in several teeth in the mouth. And as you would expect, there's a greater need then for early and urgent dental care. And if we look at just urgent dental care, roughly 18% of these kindergartners who are American Indian and Alaska Native needed urgent and emergent dental care at the time of the assessment. When we move up to third grade students, you can see the trends continue. It doesn't all of a sudden get better for these students in North Dakota. In 2018, half of our third grade students who were American Indian and Alaska Native had rampant decay. And we do have a really great model that Sheri's going to talk about, and that's a program where we have a dental hygienist working in a family medical center. And I'm going to let Sheri talk all about that program, but utilizing the data from those who are coming into a primary care center and then seeing a public health hygienist, what were the trends? The trends, again, were very similar. The individuals who attended that clinic who were white, a greater percentage of them had been to a dentist in the last year. 67% had been to a dentist, compared to only 46% of those who were Indigenous and 29% who were Black or African American. This is more data from that clinic. And here we're looking at, what was the condition of the teeth? So 61% of American Indian and Alaska Native individuals who were at that clinic had filled teeth already, compared to only 33% of those who were white. Gingivitis, you can see again the trend, the orange, which is white, the orange bar is much lower. So there are greater oral health inequities present for American Indian and Alaska Native individuals, those who are Black and African American, and other races. So now, how do we respond to that need? What can we do to improve outcomes? And Shari, I'd really like you to jump in and talk about all of the great work that you all have been doing at the Department of Health's Oral Health Program.
Perfect. Thank you, Shawnda, for all that great information and painting the picture of what is happening in North Dakota. There's improvements to be made, and yes, early childhood caries is not just a dental problem. Even as our Chief Dental Officer for the U.S. Public Health Services, Dr. Timothy Ricks, pointed out at our state oral health engagement meeting, and Shawnda also mentioned too that it's just not a dental problem. Thank you so much for all the work that you are all doing out there each and every day, and I just really want to acknowledge the great oral health program team: Jana Pastor, Tony Ruby, Melissa Kynes, Vanessa Bopp, Ada Nolan, and Dr. Drew Goebel, and Shawnda and her team at the University of North Dakota Center for Rural Health and our Wyoming Survey and Analysis Center. Really all of our partners as well for their assistance in responding to the oral health needs of our citizens of North Dakota by working on various projects or programs mentioned on this slide, which I will go into more detail about as we proceed into this presentation. But really what makes this happen is our partnerships across North Dakota and the grant funding that we have received from CDC and HRSA. Next slide, please. So with our medical dental integration project, really its interconnected nature of oral health and the overall health, public health programs to promote coordination between dental and medical providers. Vanessa Bopp, as Shawnda mentioned before, is our registered dental health hygienist, who we call our public health hygienist for grant purposes. She's working at the UND Center for Family Medicine in Bismarck. Vanessa is really part of that medical team, and she's completing dental screenings on patients of all age groups. She's applying fluoride varnish and providing education on oral health to all the patients that she's seen, and referring those patients who need further dental care to a dentist if they have identified that they don't have a dental provider. And then she's also applying sealants to those children if needed to those back molars. Really, Vanessa is also increasing the oral health knowledge among the medical residents practicing at the University of North Dakota Center for Family Medicine. She's really providing oral health education to medical residents and staff during lunch and learns. Topics are based off the Smiles for Life curriculum. Smiles for Life curriculum, for those that don't know, is a free online oral health training curriculum, and it's really designed to enhance the role of the primary care clinicians in the promotion of oral health for all age groups. Another area that we're working on is to support blood pressure screening and referral processes that address hypertension in dental offices. And this is led by Melissa Kynes, our clinical community coordinator. And we've been really fortunate to be working with a variety of dental offices across North Dakota. We have 14 dental offices in this project. It includes private dental practices, federally qualified health centers, Indian Health Services dental offices, and a nonprofit office. And really the dental providers are tracking 4 key indicators for us: the number of screenings they've provided for hypertension, the number of screenings indicated that individuals do have high blood pressure, and the number of referrals to a medical provider. And then also the number of referrals that actually received follow-up. And the dental practices for year 1 and 2 of this project, which would be from September 1st through 2018 to August 31st of 2020. We had 8 dental sites, which included IHS, private dental office, nonprofit, and the federally qualified health centers, like I mentioned before. We actually trained 75 dental providers on just refreshing blood pressure training for those professionals in those offices so that they're up to speed on any new blood pressure monitoring. And it was really the dental providers and professionals working in those offices that made a great impact to North Dakota. They screened over 27,000 individuals. They detected 1,975 individuals with high blood pressure. They referred 456 individuals for follow-up care. Unfortunately, not everybody is compliant with that follow-up referral care, which we're trying to work on, but 209 actually followed through with those referrals. And in year 3, which is from September 1st of 2020 until it goes through August 31st here of this year, we are partnering with 6 additional dental sites, and they are doing the above mentioned reporting and screening for us as well. So many great partnerships have been established within the dental professionals and those that are working at the UND Center for Family Medicine, and always looking for new partners out there. So just kind of want to put that out for anyone if you have questions or if you have any thoughts on which direction oral health might be a better suit for your community, please reach out to us. So next slide, please. We also have our CLND program, and this is led by our prevention coordinator, Tony Ruby. She is a dental assistant. And this project provides preventive oral health care to our low-income and underserved students by targeting schools with 45% or greater of their students enrolled in the free and reduced feed lunch program. So we have a temporary registered dental hygienist, Ada Nolan, who goes to our schools and provides dental screenings, dental education, and applies that fluoride varnish and those sealants to those back molars on the schools that are participating in the program. So in 2019 to 2020, you'll see the number of schools that participated here at 80, and then the number of dental screenings of the students and how many students received the fluoride varnish and dental sealant. And then just wanted to let you know that if it wasn't for our partnership with these dental providers that say, yeah, we'll go into those schools in our communities and help provide those services, Ada would have been doing 18 schools. Well, she did 18 schools on her own. 634 students had dental screenings and 615 students received fluoride varnish application, and 393 teeth were protected with dental sealants on her own. So really it's those partners that are really helping out with the program that really make a difference. And then we noticed that, you know, during COVID response, we weren't quite sure if we could actually get back into those schools. So we sent out roughly, I'll say 45,000, but actually it's 48,000 since these slides have been made, toothbrush kits to any school that needed those toothbrush kits. So it was a toothbrush, toothpaste, floss, and some dental education that went to those kiddos and to the teachers in various schools across North Dakota, thanks to our prevention coordinator. So next slide, please. Another project that we have involves a dental rotation. Really, the recruitment and retention of oral health care professionals in North Dakota is a challenge. The state has no school, dental school, and no reciprocity agreements with our neighboring states to encourage student enrollment. And really, we recognized the need to address oral health workforce shortages and the barriers to recruiting new dental professionals. So to promote this, we recruited newly graduated dentists, and it's really the help from Spectra Health and Dr. Nord and her team who goes through that process with the schools in Minnesota and Iowa to recruit those students and to really give them that exposure to the dental profession and what they do in a federally qualified health center. So those students, they really are completing mostly restorative care. But over the years, we've been able to support 2 5-week dental rotations late in the fall of 2018 and 2019 with Spectra Health help with that. So a positive, Dr. Nord was able to recruit 1 of her students back to work in her office. So really it's the partnerships that are the help of the oral health program. Next slide, please. The oral health program and the North Dakota Dental Association surveyed dentists in North Dakota on opioid prescribing in 2018, and a total of 242 dentists completed that survey. More than half had been practicing for 11 or more years, and a majority, 85%, practiced in general dentistry. And roughly 79% of the respondents reported prescribing opioids between 2016 and 2018. And 91% were registered with the North Dakota Prescription Drug Monitoring Program. However, only 52% had taken continuing education credits on addictive disease, pain management, opioids, and narcotics. Dentists who were practicing in oral and maxillofacial surgery and in general dentistry were more likely to report prescribing opioids compared to other areas of practice. And the data that you see here on the screen for prescribing opioids was what we were seeing of the practices in North Dakota. So the data was showing us that the dentists were not overprescribing in North Dakota and were using appropriately. So this kind of opened the doors to looking at other data within North Dakota on oral health, and we explored the data from the North Dakota Essence data from 2015 to 2018. And Essence data is an electronic surveillance system that consists of emergency department, urgent care, and walk-in clinic visits. And there are, significant limitations to that data, but it's really the only means that we have at this time to see why individuals within North Dakota are using our emergency departments for tooth pain specifically. So the oral health program started working with Quality Health Associates in 2020 to work on an emergency room diversion program. We completed an environmental scan in 2 North Dakota communities, Minot and Williston. And this included partners such as our emergency department staff members and the dental offices within those communities. And also we tried to get some of the participation from the community members. We were unfortunately only had 1 community member working on that. So next slide, please. Another area that we worked on was we really wanted to collaborate at a national level and a statewide level. So the North Dakota Department of Health collaborated with the CDC and the National Association of Chronic Disease Directors to host the first ever oral health state engagement meeting early this May of 2021, and we kicked it off virtually. COVID kind of put a little snafu into that. We were supposed to have it in person last year, but unfortunately we couldn't. But we convened leaders from public and private dental and medical care organizations, government, volunteers, and community organizations from across North Dakota to really engage in a discussion about how can we collectively engage in improvements to provide better access to oral health care in North Dakota. And really the goal was to have a collaborative impact and have input from not only dental providers, but those non-dental providers, the medical community as well. And another area that we are working on is community water fluoridation. North Dakota is fortunate to have 96.5% of our water fluoridated. And most of us know that fluoridation occurs when our water operators in our communities add additional fluoride to that water so that it's up to this 0.7 parts per million. And water fluoridation really is the best preventive measure for cavities within our communities. So we work collaboratively with the Department of Environmental Quality, and we also are working very closely in partnership with the American Fluoridation Society as well on this project. So that is all that I have, Shawnda. So
yes, thank you. And knowing that we do have another session, thank you, Sheri. I was just going to share that you can visit the Oral Health Program webpage for more data and statistics. All of the data are available by different groups. And then we've got all our evaluation reports that are shared in this link, and I will put these all in the chat box for you as well. And then I just really wanted to promote for those of you working in primary care or public health that we do have an oral health and primary care tele-echo clinic that's going on right now with the primary focus of trying to educate those who are not dental providers necessarily about how they can play a really strong role in addressing oral health inequities in North Dakota. And there are continuing education credits. It's free. There's more information at this link, and you can see all of the upcoming trainings. They're the second and fourth Thursday of the month.
Thank you, Shari and Shawnda, so much. Unfortunately, we've got a hard stop at 3:35, so we need to get Amber and Shari up and running, but we sure appreciated your presentation today.
Thank you.
Good afternoon, everyone. I'm Amber Slevin. I'm a clinical pharmacist at Family Health Care, a federally qualified health center in Fargo, North Dakota, and also teach at the School of Pharmacy at NDSU. I am pleased to be joined today by Sheri Renton from the Department of Health, who serves as the surveillance coordinator in the HIV, STD, and viral hepatitis department. Our objectives are to describe current trends in Hep C virus infection rates and care cascades specific to North Dakota, and then move into talking about Hep C treatment in the primary care setting as an opportunity to increase access to care. We'll summarize some of the treatment barriers as well, with some issues specific to rural populations, as well as some opportunities to overcome these barriers. So Sheri, I'll hand it over to you here.
Thanks so much, Amber. Good afternoon, everyone. So I'm going to give a quick background on hepatitis C and the epidemiology of it. I'm going to go pretty quick so I can leave Amber plenty of time, because what she has to talk about is the meat and potatoes of everything. So hepatitis C is a liver infection that's caused by hepatitis C virus. It is blood-borne. The primary transmission is sharing needles or other equipment to inject. It can be a short-term illness, but for the majority, it does become a long-term chronic infection and can lead to life-threatening illness such as cirrhosis or liver cancer. Unlike hepatitis A and B, there is no vaccination to prevent hepatitis C, but the good news is that it can be cured with treatment. Next slide. So here you can see a list of the symptoms of acute infection. The problem is that the majority of people don't have symptoms, so it's often not diagnosed during the acute phase. And we'll see the repercussions of that a little later on. Next slide. So who is at risk for hepatitis C? Again, people who inject drugs, whether it's current or former use. Those born from 1945 to 65, that's the baby boomer population, and there was a high prevalence of hepatitis C among that population. Recipients of clotting factors before 1987, recipients of blood transfusions or transplants prior to 1992, anyone with a known exposure, so this can happen in the healthcare setting or emergency medical services or law enforcement, etc. Go to the next slide, please. And then it can be transmitted from mother to child. It's about a 6% transmission rate for that. And then people who are incarcerated are also at risk, those who use intranasal drugs, and then individuals that receive body piercing or tattoos with non-sterile equipment. Next. So in 2018, the North Dakota Department of Health started a project to look at those newly diagnosed individuals that were aged 35 and under to really identify what their risk factors were. And of those, 88% reported injection drug use as their primary risk. Next slide. So who should be screened for hepatitis C? The recommendation recently changed in 2020. Prior to that, it was those in the baby boomer population should be tested at least once, and then pregnant women if they were at risk, and then anyone else at risk. But now they have changed it to more of a universal screening. So every adult should be tested for hepatitis C at least once in their lifetime. And then every pregnant woman with every pregnancy should be tested. And then again, everyone with any risk factors for hepatitis C should be tested regularly. Next slide. So now I'm going to get into a little bit of the national data, and then after that, I'll go into North Dakota data. So this first chart here is acute cases that are reported to the CDC from 2011 to 2018. But again, people often aren't diagnosed in the acute phase because they're not symptomatic, they're not seeking care. And so you can see the purple line and the diamonds at the bottom is the actual number of reported acute cases, but then the teal bars are what the estimated acute infections actually are. And as you can see, it just increases each year. Next slide. This next graph is chronic hepatitis C that was reported to the CDC in 2018, so just under 138,000 cases. To note though, not all states report chronic conditions to hepatitis C to the CDC, and so this is only those that are reported. 13 states and the District of Columbia are not included in this number. But the important thing to note is kind of this bimodal distribution that you see with the age breakdown. If we go to the next slide, you can see it a little bit clearer. So this is all cases in 2018 again. So it really increases among the millennial population. We see a drop among Gen X, and then it goes back up into that baby boomer population again. Next slide. So let's look at the treatment cascade. This is from a 2014 study of US estimates. And so the first bar is those that are infected with chronic hepatitis C, whether they know it or not. So that's at 100%. And then the next bar is the ones that are aware that they are diagnosed. So that's only at 50%. Again, people aren't symptomatic until the disease really progresses. So a lot of people are living with hepatitis C not knowing it. And then the third bar is those that are actually prescribed hepatitis C treatment. And that's at 16%. And then the last bar is those who actually are cured. So it's 9% of achieved SVR. So that's sustained virologic response. And that is identified 12 weeks post-treatment to make sure that there's no virus left in the blood. And then they are considered cured. Next slide. So just this last infographic for the national data is, again, just to iterate that there are nearly 2.4 million Americans living with hepatitis C. Again, it's all estimates, and that half may not know that they are infected. So hopefully now increasing that screening recommendation to be more universal, we will be able to identify more of those that are unidentified. Next slide. Now we'll get into North Dakota data a little bit. This graph here is all hepatitis C that is reported. So it's acute, chronic, unknown, everything. North Dakota doesn't identify many acute cases again, so everything's always locked together for our data. As you can see, it's definitely increased. Since 2010, it's more than doubled. We did see a slight drop in 2019, and then preliminary data for 2020 is again another decrease. Can't really say that's a true decrease because we don't know if with the pandemic, if there's a decrease in testing, which we assume that there has been. And also important to note that harm reduction services can really impact the rate of hepatitis C. And in the 2017 legislative session, syringe service programs were made legal in North Dakota. And so currently we have 5 operating, and you can hear about one a little later this afternoon. Next slide. I wanted to show this slide just to show that hepatitis C is a whole statewide problem. It's not just limited to the more populous counties. It really is widespread across the state in those rural areas. Next slide. So this is kind of that same graph that we saw earlier with the national data as far as the age breakdown. So this is from 2019. It's not as pronounced of a bimodal distribution, but you can definitely still see 2 humps. But the majority of the new cases are being diagnosed in those 35 and younger. So what does North Dakota's care cascade look like? I have a question mark here because we don't really know. We don't have the data currently to accurately depict it for North Dakota. It is something that we are working on, and we're going to try to actively collect that treatment data. However, we do know that not enough people are getting treated in North Dakota, and that's where Amber comes in, and she can kind of talk about her great work and how we can increase that access to treatment.
Thank you so much. So as Shari mentioned, the entire hepatitis C care cascade from diagnosis to treatment to verifying cure is really important to actually be able to eradicate hepatitis C at a population level. I'm going to focus mostly on hepatitis C treatment today with the goal of hopefully expanding treatment in primary care settings across the state of North Dakota. This has been identified by many experts as a need for a shift from that specialty care setting to primary care setting. And I'm going to start today by talking about many of the reasons why that shift has been made possible and is now being strongly encouraged. One of the most incredible medical advances in the last decade has been hepatitis C treatment. We now have agents that are very highly effective. Their cure rates are above 95% for most patients who adhere to the full therapy, which is about 8 to 12 weeks. And again, that gold standard for showing that someone's been cured of hepatitis C is that there's no viral RNA remaining in the blood 12 weeks after treatment. So these medications are highly effective. They're very safe and well tolerated, particularly compared to our previous treatments. And the treatment guidelines have been highly simplified as well. So this is in stark contrast to what our treatments looked like 10 years ago when we were using more interferon-based treatments, essentially chemotherapy-like treatments. That had a lot of toxicities, required a lot of monitoring, and if a patient could stay on them for the full 48 weeks of treatment, they still only had about a 50% chance of cure. So they were often reserved for folks who are showing more liver damage from hepatitis C, which we're now treating really everyone, whether there's liver damage present or not. So specialist involvement with this advancement is really only needed or recommended in more complicated cases, perhaps a patient who's had really advanced damage to the liver from hepatitis C or other causes, patients who are co-infected with hepatitis B or HIV, or those who are post-transplant and perhaps on immunosuppression therapies that require a little extra attention as well. With treatment previously, we would need to stage the liver with a biopsy procedure, which again is a specialist procedure. And that would often help inform whether the risks of the old therapies outweighed whether the benefits of our older therapies outweighed the risks. For example, someone who still had a really healthy liver, per the biopsy, may not be treated in order to prevent unnecessary toxicity from the medications. With the medications no longer being associated with that toxicity, we still want to know what stage that liver disease is in generally. If it's really advanced, that can change the therapies we use and maybe even subsequent specialist involvement, although it doesn't really inform who gets treated anymore. We really want to treat everyone who has hepatitis C. One of the major reasons that we're calling for a shift of Hep C treatment to primary care is the risk of patients being lost to specialist referral follow-up. And I am sure if I have any primary care providers or nurses in the audience here, you know that this happens a lot. We certainly saw it a lot in our organization as well, but there are a variety of barriers to seeing a specialist, whether that be location, particularly in more rural North Dakota. In case any of us have forgotten what it's like to drive in North Dakota in the winter, I included a little weather map picture there. Sometimes cost is higher, or it's just harder to navigate some of the bigger medical centers that have specialist care. So there's been a big call to shift to more primary care-based treatment. With this call to shift has come along with many supportive resources to help the general practitioner treat Hep C in their setting, in their everyday clinic. And Shawnda had referred to this previously, the ECHO model. This is a model that supports general practitioners in providing a variety of different specialty type services to their patient populations, and therefore extends, the specialty knowledge of a small group to a pretty large patient population. So here at Family Healthcare, we're a part of one of these that operates out of Hennepin Healthcare in Minneapolis. And this has really enabled us to bring forth some of our more complex cases rather than having the patient seek a specialist. Although I'll say, over 95% of our cases we're fully equipped to manage just right here in primary care. There are many studies, and time is limited on how much we can go into these, but I have a few in our reference section, that there are equitable treatment outcomes for hepatitis C, meaning that patients start, complete, and are cured by treatments in the primary care community-based settings as compared to specialist settings. And many of these models are run by nurse practitioner or physician assistant, advanced practice type practitioners, and many pharmacist run clinics as well. Since the diagnosis of hepatitis C doesn't require really refined diagnostician skills and is very heavy in pharmacotherapy, this has really taken off as a place for pharmacists to thrive and make an impact, particularly in settings where access to a physician can be more difficult. So shifting gears, I want to talk a little bit about our model at Family Healthcare. And there are certainly many different ways that these clinic models can look, and many unique models out there, but I wanted to share ours. So ours is an interdisciplinary collaborative team. We have 2 advanced practice providers, myself, a clinic-based pharmacist, and then a pharmacy school intern who helps us quite a bit with our care coordination and even monitoring prior authorizations for the treatments. We have really strong partnerships with our nursing teams and our in-house pharmacy as well to help with some of the logistics of the care coordination and medication dispensing as well. And we've been doing this a few years now, so I want to share kind of how our model has evolved. We've learned over time our referral sources are primarily out of 3 buckets. Most often the primary care providers within our clinic or the providers in our clinic that may not be someone's primary care provider but are providing medication-assisted therapy for patients with a substance use disorder and then are screening for hepatitis C. Community referrals from treatment centers for substance use disorders as well as public health offices. And then a lot of family and friends. We have people that come in just sharing that their brother or friend or spouse was treated with us and they would like to pursue that as well. They just weren't really aware of access, and there are a lot of misconceptions about being able to access Hep C treatment that are out there. Once our patients establish care, one of the most important things for that first visit is talking about what's needed in order to start Hep C treatment, because unfortunately, as it stands now, with the clinical workup and insurance requirements, a patient can't leave after their first visit with the treatment. It takes a little bit of time and a few follow-up appointments usually to get them started, although there's a lot of work being done to try to simplify this and get medications in people's hands sooner. So we take advantage of this time by ensuring patients are up to date on their vaccinations, particularly Hep A and B indicated by CDC for those with liver disease. We are fortunate to have imaging in our clinic that we can do the liver staging with. For clinics that don't have this, there are several lab tests and calculators that can provide very trustworthy estimations of liver staging and really minimize how many patients actually end up needing imaging, which is great and reduces another barrier if that's not immediately available. And then often we're obtaining outside records to get more history of the disease, because we have a fairly transient population, particularly within our Hep C clinic. So a lot of times we have records from prison or other clinics that we're looking into to learn more about the history of their infection. So typically about 1 to 2 more visits, as I said, that we continue the clinical workup and also are working toward our insurance coverage requirements, which for the state of North Dakota with Medicaid, there are lengths of sobriety that are needed depending on whether or not the patient has completed treatment, how long they have reported sobriety, and these are changing and continuing to lighten up, but they do still often extend our timeline. We also use that time to get to know our patients, ensure they're ready to commit to that therapy, adhere to that therapy in a good place to be adherent and get a good outcome and avoid any breeding of viral resistance that can come with incomplete treatment. Once we're fairly certain the patient has met the insurance requirements, if we know them, and once our clinical workup is done, we submit a prior authorization for the medications to insurance because they are fairly costly. And I'll just put in a point here. It's really best to know those insurance criteria from the very start so that that's communicated to the patient and there's no surprise once the clinical workup is done if another month of sobriety labs, for example, is needed by their insurance. This is not always publicly available, so just whenever possible, it's helpful. And once they're approved, we have a very intentional treatment initiation visit that we talk about the medication, how it works. We relate the mechanism of how it works to the importance of adherence to really stay on top of that viral replication process. We talk about side effects, which although are very mild, we do have an opportunity to help patients manage them. I provide a very in-depth reconciliation of medications between our records and what the patient is taking to ensure we don't have any drug interactions, and then coordinate follow-up as well. While patients are on treatment, we reach out to them a few times via phone and typically see them in person 1 to 2 times. There are many practices that only do phone check-in with a care coordinator and then triage issues to a provider if needed. And then, of course, we want to coordinate for that patient to have labs done afterward to verify that SVR12 was achieved. In our practice, we like to document the treatment start and end date and a final adherence assessment, just in case they're part of that few percentage that don't achieve SVR12. Insurance may question adherence, and we can submit those notes if needed. We ensure that we educate on preventing reinfection. So what are the routes that someone could be reinfected? Because treatment does not confer immunity, and we don't have a vaccine for hepatitis C. When appropriate, we also want to connect to patients with harm reduction, such as syringe exchange programs, and then ensure that we are able to obtain and document the cure. After a patient is cured or achieves SVR12, there's really no further work that needs to be done for hepatitis C unless they have ongoing reinfection risk factors such as injection drug use, in which case we'd want to monitor annually the viral load, not the antibody, which will remain positive. That's our body's memory cell, so that will be positive for life even in someone whose hepatitis C has been cured. And then, if appropriate for those with more advanced disease, connect them with appropriate specialist care for follow-up. We have seen about 150 patients to date, and about a third of those are either on treatment or have completed treatment. I'm just going to summarize this slide for the sake of time. We had one patient that virologic failure was suspected, but actually a very interesting case that our echo specialist helped us out with, and with some further monitoring found that they were indeed cured. So we're excited. We haven't not yet had someone fail therapy. We have had one patient lost to follow-up while on treatment. So moving to our barriers, why is it that only about a third of our patients have started on treatment? The pre-treatment process, I think, can be difficult for patients to stick with long-term, particularly if they are part of a more transient population, largely because of insurance requirements with regard to sobriety. In our population, we have a lot of folks that are post-corrections or in treatment facilities or homeless, so they're not in Fargo-Moorhead for the length of time needed for that prior auth, those insurance requirements. And then we have kind of some unknown lost to follow-up, don't show up, not sure what happened. Sometimes we connect with them a year later and are still able to move things forward, but we do suspect there could perhaps be some misconceptions that they're not going to get on therapy related to some of the stigma associated with Hep C. Perhaps they had a provider change or a psychiatric or substance use comorbidity that's limiting. I have outlined some general barriers here, and all of these slides are available online. But in general, the expense of medications requires insurance coverage, which comes along with quite a bit of paperwork, although again, this is improving all of the time. And for anyone who is interested in starting treatment, I'd be happy to help you navigate this and get started. Substance use disorder comorbidities are common and can not only contribute to insurance restrictions, which do need to shift to a more treatment as prevention approach in such as Minnesota Medicaid has done, and that's a topic of its own, but also to ensure that we're connecting patients with resources to prevent reinfection. And then largely access to care. So there's no longer a specialist requirement to prescribe and have Hep C treatment covered in North Dakota. However, as we know of right now, there's no one treating hepatitis C on the entire western half of the state and many communities within hours of treatment services. So I would encourage anyone in those communities reach out to me, and I'd love to help get things started. The next few slides outline some helpful tips or considerations if you're interested in providing primary care-based Hep C treatment. What would be some essential roles that can be filled by many different people? Some helpful clinical resources that you can access online. The Medicaid treatment criteria in order to obtain insurance coverage, and then a few resources for those who maybe learn best by talking with someone or being part of a group, including our link to Project Echo and our contact information here for myself and North Dakota Department of Health is at the end, just after our summary here. So in short, there's a lot of work to be done to eradicate Hep C on a population level from diagnosis to cure, and primary care-based Hep C treatment, especially in rural setting, can help overcome a lot of access barriers. Thank you so much for your time.
Yeah, thank you, Amber and Shari. And I apologize for needing to rush you, but we do have this hard stop that was at 3:35, and we've just got barely any time in between this session and the next one. So, but thank you. And again, folks, remember that the slides are available so that you can look through them. Another excellent presentation. So thank you, everybody, for attending this session.
The exhibitor message for the Dakota, and I promise to deliver. So I'll just share my screen really quickly. Let me see here if I can. Let's see here. Well, it doesn't look like I'll be able to get these slides to work, but that's okay. So I'll just go ahead and introduce the Dakota. There we go. We have 3 funding opportunities. We have a professional development RFA, a scholars program, a clinical scholars program, and then also pilot projects that come out. So we focus on teamwork. The Dakota encourages clinician and non-clinician teams to participate in research that works to address cancer and disparities in treatment and access in North and South Dakota. Our next round of RFAs will be opening up in the fall. We are actually currently going through our renewal draft for our second round of 5 years of funding through the NIH. And we're working to connect scholarship with community-driven research in our priority communities. The stuff that we do on my core includes culturally competent human subjects research training. And we would really encourage everybody to go ahead and check out our website, and I'll put that in the chat here. Again, we do have another round of RFAs coming up in the fall. So if you have ever thought about potentially participating in funded research that addresses cancer, cancer care, treatment, access, and other disparities issues in our communities, I would highly encourage you to do that. And I will include my information in the chat.
You are in the intensive 4B, and there's 2 parts to this, a part 1 and a part 2. I'm going to go ahead and actually go through the bios for the speakers for both parts of this, and then we'll turn it over to the part 1, which is the growing and going together local food opportunities. So to start out with that session, we have 2 speakers, Katie Johnke and Jan Stankiewicz. So Katie Johnke is a licensed registered dietitian, nutritionist, and certified lactation counselor in Bismarck, North Dakota. She is the Nutrition Services Coordinator for Bismarck-Burleigh Public Health and Worksite Wellness Coordinator for the City of Bismarck since 2013. She received her Bachelor of Science in Dietetics from the University of North Dakota. Katie works in many different capacities in the Bismarck community, whether it be active transportation, healthy food systems, or breastfeeding support. Katie has a passion for improving community health through public health education and efforts. Additionally, Katie has experience working with federal and state-funded grants that aim to improve chronic disease, maternal and child health, breastfeeding rates, and community livability. She currently serves on the board for North Dakota Nutrition Council and the steering committee for the local Community Health Coalition, Go Bismarck-Mandan. Jan Stankiewicz is an area specialist in community health and nutrition with NDSU Extension. Her work revolves around policy, systems, and environmental changes to address childhood obesity. She is certified as a technical assistance provider for Smarter Lunchrooms, serves on Bismarck's Healthy Community Coalition, and board member for Bismarck-It. Jan has provided wellness education throughout her career, including sports programs, motor skills programming for preschoolers, grant writing, and development of the SNAP incentive program. Jan was honored to be selected as a fellow in the 2016 NIH Residency Training in Bethesda, Maryland, and was a member of the 2015 cohort of USDA Tribal Research Fellowship in Washington, D.C. Jan received her Bachelor of Science from UMary in Exercise Science, a Master of Science in Exercise Science and Nutrition from Montana State University, and a certificate in the Master of Public Health program with a concentration in American Indian Public Health from NDSU. The second part of the session is the Good Neighbor Project, SSP/harm reduction, and Jennifer Pelster is the presenter. Jennifer was born and raised in North Dakota. She graduated from the University of Mary with her BSN in 2008. She has a background in correctional nursing, working at the North Dakota State Penitentiary, North Dakota Youth Correctional Center, and North Dakota jails. Through these experiences, she developed a passion for HIV, hepatitis, STD testing, and counseling. This helped her to recognize the increasing need for a syringe program. She has been a public health nurse with the Custer Health in Mandan, North Dakota since 2013. She helped get the Good Neighbor Project started in 2018, which was the first syringe exchange program in North Dakota. All of our presenters in this session have indicated that this presentation will not include discussion of any commercial products or services and will not include any discussion of off-label and/or investigational uses of any product or services and will not include trade names. Just a reminder again, please take the pre-test and the post-test and any questions put in the chat, and we'll turn it over to Katie and Jan to do the part one of this session.
Okay, so thanks for being with us today. Katie and I are excited to share a little bit of what's going on in the local food effort area in Bismarck community. So Go Bismarck-Mandan is a healthy community coalition centered around the work in Bismarck and Mandan. We will just kind of take you through some of our journey in regards to coalition work as well as local food work. So today, specifically, we'll go over some benefits that are a little bit more common and maybe some that are not so commonly known about local food opportunities in your community. Maybe looking at who to engage and how to engage those folks in your community. And then also having you take a look at your own community in regards to local foods. So a bit of history from the Go Bismarck-Mandan perspective. Again, it's a healthy community coalition. So we thrive on the diversity and the strengths of our community partners. There's many partners that we kind of pulled together throughout the years and all working on aligning our goals and missions with the idea that a healthy community is what is going to help us each reach our different missions. And so we kind of keep this saying in mind when we're doing some coalition work in our area. To go fast, we can go alone, but to go far, go together. And that is definitely some of the mantra that we try to focus on, is that while we are including and engaging many different partners from different organizations and different sectors, it isn't necessarily the speediest work, but sometimes it's what will take us the farthest and in the strongest way. So a bit of history about Go. It was established, the coalition was established in 2009. So we've been around for a little over 10 years, and it was originated from both mayors in both the Bismarck and Mandan communities. They had kind of charged the community with dedicated health and wellness efforts. A lot of that centered around specifically food and nutrition work, as well as physical activity. And those kinds of things can have a direct impact on individuals who participate in those activities. So if it's looking at displaying caloric intake information within local restaurants or food service establishments. Or if it's, specifically working on hosting an event that provides awareness about biking or walking in your community, or providing certain information at health fairs. Through the years, we had seen a need to kind of expand our thoughts and ideas about health and wellness and community livability. So as you can see on the map and the road that GO has been on for over 10 years now, we've done some different work, expanded some of the ideas around health and wellness. So things that include smoke-free playgrounds, which included policy changes within the Park District, one of our major partners in the community. Adopting and implementing farmers markets in the community that focus on family-friendly events, that also accept SNAP benefits to increase access to local foods for all community members. Including demonstration projects, so the pop-up pathway, showing how folks can walk and bike and roll from downtown Bismarck to the riverfront, and then also another demonstration project including curb extensions in one of the main intersections in downtown Bismarck. And those demonstration projects are a really nice way to kind of give the community a taste of what it could look like without having major infrastructure changes or funding associated with that. GO has kind of gone through a few different iterations of strategic planning and work groups and action plans to kind of fit and adjust to the community needs. And then, as you can see too, as we kind of wind down further into the road, down the road, the adoption and establishment of a local foods coordinator position came from the work within GO Bismarck-Mandan, as well as some community partners. And all while we are looking at and have our sights set on a healthy lifestyles for all. That's the vision of GO. I'll hand it off to Katie.
All right, so I'll take you through what led up to our local foods coordinator. We had the opportunity to bring forth to the city of Bismarck through a call for projects that they initiated through their strategic plans. Fortunately, other major taxing entities in the community, Bismarck Parks and Recreation District and Bismarck Public Schools, were also going through their own strategic plans at the exact same time. And what better way than to align with these three entities that work together very often than to align and work in those local foods opportunities that we were wanting to achieve and take to the next step. And so thinking from a city standpoint, looking at the workforce and the economy and the people, the community of Bismarck, where, Parks and Rec with the play and the recreation and all ages, and then with schools, students, and education, and how can we work local foods into all of these areas? And since they were going through the strategic plans all at once, this was a prime opportunity for our community. And so when we had to go through the city of Bismarck with their call for projects request that came out of their strategic plan, we wanted to align with their strategic focus areas that the city of Bismarck's plan highlighted and where local foods fit within these 5 areas. So taking a look at signature spaces and how local foods and some of the current things we were doing, how that can impact in that area. And so thinking about our green and outdoor space for our markets or our community orchard, the opportunity for the local foods and local arts culture. And so how local foods can enhance our community with a place to go and a place to be. And our current work in our Bismarck and community orchard do serve as a kind of signature space within local foods. And so being able to enhance that and take it to the next level was one perk of this potential for a local foods coordinator. Focusing on all ages and wages. And again, this aligns with both Parks and Rec, Bismarck Public Schools, and the City of Bismarck. We really want it to be a community-focused intervention and opportunity. And we really want the livability to meet all needs and having those opportunities for intergenerational support. Increasing access for all, regardless of status or demographics or location. Thinking of some of the current work that we are doing, Bismarck implements SNAP and BPUTS programs. We have fresh food donations, ramping up our farm to school program, which does exist within Bismarck Public Schools, but at a very small level. And so making that more robust for our students and youth and teaching them where our food comes from was super important part of this local foods opportunity. And then enhancing the orchard and garden spaces that could help promote food security, because especially where they're located within Bismarck, and just allowing that opportunity for all people to benefit from this, this position and what it could do for our community. Highlighting social health and focusing on those personal connections and enhanced relationships. We all know how important social health is, especially after this past year. And so having that local foods piece, really find a way to sneak that into all of the work they were doing. Looking at the comprehensive approach to health and wellness, that it's a holistic approach. We're not just talking fruits and vegetables grown in the gardens. We're talking about the bigger picture and communicating that to our community. Integrating local foods as a staple for a healthy lifestyle and teaching youth where their food comes from through that farm to school, getting more people to come to market and understanding what it means to be part of a community and that social piece that comes along with it. And so all of these areas that within the strategic focus area was important to also align with our local foods work. Looking at the economic benefit, and this is a key piece, especially when we were presenting to the City of Bismarck. You know, what can this do for our community from an economic standpoint? And so how this can enhance those small business opportunities for producers and growers and farmers. The sole job creation of the local foods coordinator. So again, that employment opportunity there. But then what that means to keep businesses, that attraction for workforce, the residents that need different spaces, events and programming. There's so much more opportunity when we have a collective focus on local foods work that it can really give back to our community in many different ways through Bismarck and the farmers market. So not just through the dollars exchanged there that do benefit the producers, but going beyond that and what it means to stay local, support local, and even support then within the state of North Dakota as a whole. And then finally, looking at the complete connectivity. So thinking about how do all of these pieces intertwine, and how do we all collaborate together to have a robust local foods program? Because we know the benefits behind it, but being able to showcase that to the community and to our partners, that there really is a long-term benefit for us. Looking at the approach between producers and school nutrition programs, and so what that means for down the road for, again, that robust school program, farm to school program. And then being able to connect people through local foods. So again, kind of going back to the community, the social connections, focusing on arts and music. So there's more to it that local foods can do than just when you think of maybe growing a tomato plant and selling that. There's more to the picture, and that's really what we wanted to enhance with this opportunity for a local foods coordinator, and we felt Bismarck was ready for.
Yeah, so then after taking us all through how GO kind of got involved in the local foods movement within Bismarck and Mandan, and then some of the rationale kind of behind it, connecting with other local organizations and agencies and decision makers, that kind of brought us to, in 2019, Go sought the opportunity from the city of Bismarck in their strategic planning sessions, like Katie had mentioned. They put a call for projects from any and all community members, whether they were associated with an organization or not, and regardless of status. So there was no requirement as, being in a 501c3 or anything like that. So go put together an application with the idea that what seemed to be the missing link in local foods work was a dedicated position, having somebody's primary responsibilities within employment to take on local foods work. In a lot of ways leading up to that, it was volunteer, or it was kind of an add-on, other duties as assigned type of thing. So go put together an application asking the city of Bismarck to fund a proposal in a shared funding structure with the other taxing entities in Bismarck. So we asked the city of Bismarck, we asked Bismarck Parks and Rec, we asked Bismarck Public Schools, and we also asked Burleigh County, all with the idea that as they receive tax dollars from their citizens and residents, that it would benefit all of their constituents. We asked for a full-time position that would be benefited. So it would be an actual employee. It wouldn't be a consultant or some sort of contract or tied to a grant, as it had been, as some of the work had been in the past. So going through the proposal process, the outcome of our 2019 ask was that 3 of the political subdivisions did jump on and say yes to our proposal. And Katie and I will often still kind of give each other a shared glance, and it's in a little bit of surprise that 3 of them did say yes. Oftentimes we get used to lots of no's. So what we got was, again, the 3 subdivisions providing funding and support. We ended up with a part-time local foods coordinator position, and they are technically considered a Bismarck Parks and Rec District employee. So not exactly what we wanted, but definitely a step in the right direction. And we are incredibly grateful and honored to have the support of the City of Bismarck Parks and Rec and the Public School District. So after the proposal process and the establishment of the position, our local foods coordinator started in March of 2020. And without anything really else to mention around that time frame, but stepping into a brand new position with so many partners supporting it and funding it in March of 2020, you can venture a guess and to all kinds of challenges and things like that are associated in that time frame. However, all that said, our local foods coordinator did some really amazing things and kind of adapted and shifted in ways that we weren't really expecting. But with what was happening in our community and across the state, it was there were a lot of really great things. So one of the main ones was the community orchard had significant increases in engagement, the creation of Adopt a Row and sponsorship opportunities to get folks involved with the community orchard, not only community members as individuals or families, but as businesses and organizations, and then they can provide some of that sustainability and support that is needed with the community orchard. They did a grab and grow program with the public school system. They partnered on a victory garden with a correctional facility in town where the detainees were growing the food, and then the food went to some schools that were in need of fresh food donations. And then also one of the outcomes of having this local foods coordinator come on board was a lot of community awareness, creating more of an online presence. And again, going back to what was kind of missing in this area in our community was that nobody had dedicated time or space or funding to work on those sorts of things. And so with the local foods coordinator, they were able to reach hundreds of kids with growing kits, getting into some presentations and creating different systems and processes that we've kind of been waiting for and wanting for quite some time. And now we're here in 2021. And so currently our local foods coordinator works on in basically 3 major priority areas. They work with Bismarck-Burleigh is one of the farmers markets in town. Lots of the work around vendor recruitment and vendor relations, as well as promotions and events and education. So really kind of strengthening what can be offered at Bismarck-Burleigh with a variety of vendors, increasing our agricultural producers, but then also getting into the community and partnering with other community partners on events and promotions and providing education around farmers markets and local foods. Another area that our local foods coordinator primarily works on is farm to school. So Bismarck Public Schools has worked a little bit within that sector, but they were incredibly eager to kind of ramp up their farm to school offerings. So again, kind of tying into the farmers market piece is, and farm to school is also vendor recruitment. So you can see how they kind of overlay and they aren't all working separately. So as more vendors are recruited into maybe the farmers market scene, you can kind of extend that or ripple it into public school districts or private schools as well. They're working on kind of creating some efficiencies within farm to school work, kind of enhancing the ordering system, figuring out logistics with delivery and aggregation, because as a large school district in Bismarck, there's just many moving parts. And so just kind of streamlining a lot of those steps and those pieces. And then also educational opportunities. So farm to school isn't just about local foods getting into kids' bellies, but also getting kids out to the farm. So things like field trips or getting farmers connected with schools and providing educational opportunities there. And then again, the community orchard, as we mentioned a couple of times, increasing volunteer management, increasing sponsorship, and which helps with the maintenance and engagement around the community orchard. So as we are just over a year into this local foods coordinator thing in Bismarck, we always just, they always say that it's important to know where we came from and where we've been in order to know where we're going. So you've heard some of our story. We do have our eyes set on success, and we aren't yet sure what that even looks like. It will take many of us to get there. And like we said at the beginning, we aren't aiming to see how fast we can get there. We're here to see how far we can go. So as we keep these, a picture of these carrots in mind, they're so varied, they're so different, but growing so well together. So thank you for your time today, and I look forward to any comments and questions.
Thank you, Katie and Jan. I think we'll turn it over to Jennifer now for her portion.
My name is Jen, and I am the Good Neighbor Project Coordinator at Custer Health in Mandan. We were the first syringe exchange program in North Dakota. So today we're just going to kind of go over a few things, what exactly a syringe service program is, why North Dakota needs syringe service programs, a little bit of the legislation behind the programs, and then exactly what our program does. So what is a syringe service program? A syringe service program are community preventative programs that can provide a range of services, including linkage to substance use disorders, treatment, access to and disposal of sterile syringes, injection supply equipment, and vaccinations, testing, and linkage to care and treatment for infectious diseases. Our program does a little bit of all of these things and then a little bit more. Why does North Dakota need syringe service programs? This was a big question on my mind as I was working in the correctional facilities in the jails, especially with the hepatitis C rates that I saw with doing testing. And with that, here's just some information on HIV, AIDS, and hepatitis C in North Dakota. These slides are from 2018. And like previously stated in the hepatitis C presentation, it's not just in the populated areas. They're all over the state. They affect rural areas, both hepatitis C and HIV. So as I was saying, this is just some information on the hepatitis C and HIV in North Dakota. These two represent the total cases in North Dakota based on county and population. Like previously stated in the hepatitis C presentation, it's not just, the larger cities. It affects every county, rural areas as well. And last statistic that I was able to find, December 31st of 2018, we had a total of 452 people in North Dakota living with HIV/AIDS. We do see it with our syringe exchange program, but predominantly we see the hepatitis C. We do track reported overdose deaths from our participants. This is just some state overdose statistics from the CDC. We have been seeing an increase in overdose deaths, and especially with COVID and people being isolated and the mental health aspect that comes along with addiction and injection drug use, we have seen a large increase in reported overdose attempts, and we do have some reports of some deaths. There are some community benefits for having a syringe service program. It provides participants safe disposal of needles. It also provides people in the community a safe place to dispose of their syringes as well. So whether they're diabetic, they're on immunologics, they can dispose of their syringes there too, so people aren't trying to steal them. It reduces needle stick injuries in the community, like I said, because we do take those syringes and needles from people in the community, and it also reduces the overdose deaths. People who inject drugs who are participating in a syringe service program are 5 times more likely to enter and successfully complete a treatment program and remain in recovery. Syringe service programs also help reduce the cases of new HIV and viral hepatitis infections. A little bit of the legislation behind syringe service programs. In 2017, legislation passed a bill that allowed syringe service staff to legally collect injection equipment and syringes without the risk of penalty for prosecution for drug paraphernalia. This is an ongoing battle with some of our participants. The misconception that they are protected from prosecution. Hopefully in the future that will be cleared up, because a lot of people report that they would have more people participating, friends and family, if they weren't going to be prosecuted for having paraphernalia, if they're in the program. The possession of drugs, obviously that's a whole different ball game, but we do get a lot of questions about that. And then in 2019, legislation was passed that the North Dakota Department of Health is the final authorizing agency. We do submit to them biannually reports of our program, and we do have an annual plan and reauthorization that we have to submit. And then no state general funds can be used to purchase injection equipment. That includes syringes, needles, alcohol pads, tourniquets, those types of things. And we also cannot use state fund, or you can use state funds to develop and implement a plan. So what exactly is the Good Neighbor Project and what do we do? every client who participates in our program, we review the expectations and responsibility a minimum of biannually. Some participants need to be reminded of them more frequently, but we review them as necessary. We do provide testing for HIV, hepatitis C, and STDs. Every time they come, we do a client assessment. We provide harm reduction information and education. We check immunization status on all participants. Every visit, we assess their needs for referrals and make appropriate referrals as necessary. We provide education, not just on things related to mental health and injection drug use, but we will provide education from wound care to diabetes, heart disease, nutrition, whatever the client may need or have questions about. And then we do provide naloxone training, not only to our participants, but anyone in the community. Some of our expectations and responsibilities are they must be 18 years old. We do not check IDs, so it's based on what they tell us. We do not allow children at the exchange visits. If someone shows up with a child, we will tell them they need to go home, find a babysitter, but we don't allow them at the exchange visits for obvious reasons. Participants all get an ID card upon enrollment, and every 6 months, they must present that card when they come to their visits. They do need to respect our staff, other clients in our building, the surrounding businesses, and the neighboring properties. We have had to suspend some clients because of profanity, excessive driving in our parking lot, and some of those kinds of things. Clients must return used syringes to our program in order to get new ones. So it's not like they can just show up and get new supplies every week. They are required to return used supplies to us. They can make no threats to staff. We do not tolerate violence or inappropriate language. Like I said, we had to suspend a few people. And then we do not allow using on our premises or neighboring properties. If we get reports of that, we will question the person. We will remind them of the expectations, responsibilities, and then the next time they will be suspended from our program. The testing, we do require HIV and hepatitis C testing every year. We do the rapid testing. If the rapid testing comes back for antibodies, we do draw RNA and confirmatory tests. We also offer gonorrhea, chlamydia, and syphilis testing as well. Our client assessments generally include just general demographics, where they're living, if they have stable housing, if they're couch surfing. We gather information on their usage practices, so how often they're using, how they're using, whether they're injecting, smoking the drugs, snorting the drugs, taking them orally, using suppositories or booty bumping. We get their history of overdoses, if they've overdosed in the past at all, how many times they've overdosed, and if they've overdosed since their last visit. We assess their needs for education and referrals. We have referrals anywhere from housing to job service to social services, behavioral health, food and clothing. We do have Face It Together in our office during our exchange hours. They are a peer-to-peer moderator, case manager. They are extremely beneficial to our clients. A lot of our clients are more open to meeting with our Face It Together staff just because they know the fact that Teresa and Gina, who we have in our office, have been previous users. They're in recovery. They kind of know the struggles and stigma that come with injection drug use. We do check the immunization status of everyone. If they are not current on their hepatitis A, hepatitis B, and tetanus, we do offer vaccines at those visits. In the fall, we also offer free flu shots to all of our participants, and we're currently working on a plan to vaccinate for COVID if they haven't already been vaccinated. All of this is documented on a flow sheet. That way it's a quick glance for our staff. So that way we know what needs to be done at future visits. We don't have to go flipping through pages of documentation. These are just the examples of our flow sheets that we use. The flow sheet is kept on the front left side of their paper chart. And then the encounter summary is what we fill out at each visit. With the harm reduction, we provide them safe injection supplies. There's a picture of what we supply them. We have the biohazard container that they are required to bring back to us with their used syringes. The injection supplies include alcohol wipes so they can clean the injection site, the little tin cookers, so that way they have something clean to mix their supplies in. We provide them cotton filters, waters, tourniquets, hand sanitizer, because a lot of our people are homeless or couch surfing, so they don't know where they're going to stay day to day. If they have wounds, we will assess the wounds, refer them to healthcare as needed. We do provide them antibiotic ointment and Band-Aids if it's something minor. We also provide condoms, safe sex kits, dental dams, and lubrication. And like I said, we do provide naloxone training and naloxone kits. The immunizations, like I said, we make sure that, or we try to keep them up to date with their hepatitis A, hepatitis B, tetanus, and then we offer the flu shots, and we're working on the COVID. Assessments for needs and referrals. Like I said, we screen them at every visit. Substance abuse treatment, healthcare services. A lot of our participants don't seek appropriate healthcare services just because of the stigma and discrimination that they receive once healthcare providers find out that they do inject drugs. A lot of the times when we refer clients, it is for abscesses that have turned into cellulitis. We've had some that have had necrotic instances from injecting or missing their shot. We do the testing and treatment. Anyone that's hepatitis C positive, we do refer them to a primary care provider. Anyone who tests positive for HIV, we do refer them to the Ryan White program. Social services and behavioral health, housing, food, clothing, and then a lot of our participants do use tobacco, so we offer them the ND quits information. We do have a tobacco coordinator in our office as well, so if they want to meet with Brady, we arrange that for them as well. Some of the education, like I said, we do a lot of educating on HIV, hepatitis C, and STDs. A lot of the harm reduction and safer injection practices include the not sharing. If they are reusing their own supplies, making sure that they're cleaning their own supplies with bleach water, educating them that injecting in your neck and in your groin are not safe places. Some people have poor veins, so we try to help them find ways that they can be more successful, so that way they aren't having those misses and causing infections and abscesses. And there again, anything that the clients might have questions on, from diabetes, heart disease, nutrition. And with the naloxone training, like I said, we go over their overdose history, how many times they've overdosed, when the most frequent time was, what the symptoms of an overdose are. We do have some participants who have never witnessed an overdose, or they've never overdosed, so we kind of go through what to look for. They do watch a training video. It's a 3.5-minute video that is actually on our website. So if they ever want a refresher or show family members, they can just go onto our website and watch it there. They observe the staff drawing up the naloxone and then injecting into a demonstration muscle. And then we have them show us that they can draw it up properly and inject it properly into the thigh. We have a 1-for-1 plus transaction model. What this means is that in order for participants to get clean supplies, they need to return their used supplies to us. Right now, we provide a maximum of 20 syringes per week. A lot of that is based on funding. The biggest barrier for our program is the funding for supplies because we cannot use state and federal dollars for it. All that money comes from grants and donations. And these are just some pictures of what clients have brought their syringes in if they've been stopped and law enforcement takes their biohazard bucket, or if it's been stolen or lost. They're pretty creative. In our Mandan office, we do have a kiosk on the south side of our building. This is accessible to anyone in the community to dispose of their diabetic syringes, their immunologics. We have some veterinarian people that drop off some supplies in our kiosk as well. The thing with that is that we just ask that people put them in a hard plastic container with a lid, whether it's a pop bottle or a laundry detergent bottle, just so that way we don't have loose syringes laying in the kiosk. And just some current statistics. We currently have 289 enrolled participants from a variety of counties. We don't limit where our participants have to live. We will serve anyone that can get to our office. Since the program opened, we've distributed roughly 71,000 syringes and have had returned 55,000 for a return rate of 77%, which is above the national average. In our kiosk, we have collected 325 pounds of community disposed syringes and supplies. 160 of our participants are hepatitis C positive, for about 55% of them being hepatitis C positive. Of those 60, 10 participants have seroconverted. And what that means is when they enrolled in our program, they were hepatitis C antibody negative. And then at some point for their retesting, they tested positive. So whether they were infected at enrollment and it was just too early to detect, or if they've picked it up since then. It's still a fairly low number of transmissions. We do have one person who has HIV. 40% of our participants report a decrease in injection drug use, which means how frequent they're using or how much they're using. And then we have had a 65% decrease in sharing of supplies and needles. And as of May 1st, we have provided 1,182 doses of naloxone to our participants and a reported 263 saves. And a save means just anyone who has come through the overdose. They might have been transported to the hospital via ambulance or seen health care. And then just some more current statistics, just the number of referrals that we keep track of. Like I said, the 174 healthcare referrals because they're really hesitant to seek healthcare. We've had 131 referred for substance treatment. That doesn't necessarily mean they go, or they might go for a few days and then they leave. We don't track how many people are in recovery because it is a anonymous program. But we do have about 5 clients that have come back to us and so that they successfully completed treatment, that they are in recovery. And so they check in every now and then. So that's always nice to hear. The number one drug reported in our area has been meth, with just about every participant using meth. Next is the marijuana. Heroin is pretty high. prescription pain meds, and then it kind of trickles down from there. And out of our participants, 69 report that they are homeless or couch surfing. Some of our funding sources are the Regional Resource Network. They provide funding for staff, education, and educating our neighbors and community members. NASN, or the North American Syringe Exchange Network, they helped provide startup kits when we first opened. Otto Bremer, they provide funding for our supplies, our staff time. With that funding, we purchased our kiosk and hopefully soon to expand our program. The Comer Family Foundation is for staff and supplies. State funds can be used for disposal and staff time and disease education and testing, but we cannot use it for the purchase of supplies. And then the State Opioid Response Grant provides funding for our naloxone and then our medication lock boxes. Our program started on January 16th, 2018. Dr. Kaspari is our medical director. We currently have 4 staff and me is 5. We're looking to expand to Beulah in August. We were going to open prior to COVID, but that got put on hold. Our program is in Mandan is usually open Tuesdays, Wednesdays, and Thursdays from 1 to 4 p.m. But due to COVID, we had to cut back to just 1 day a week on Tuesdays from 1 to 4. I'm happy to announce that starting next week, we are expanding to Tuesday afternoons and Thursday afternoons. And we will also start taking new participants as well next week. Any questions?
Jennifer, there was a question out there asking if you use an electronic medical record.
Currently, we do not. Just for our staff, it's just easier for paper right now. Hopefully someday we can transition into an electronic medical record. We do report to the state Maven reporting system, but that's just a lot of our statistics that we have to keep for the state.
All right, there's a couple comments out there, one thanking you for the important work you're doing, and one stating they're glad to hear you were getting closer to normal hours after COVID. Thank you so much for your presentation.